Okay, everyone. So good morning. Thank you for attending this morning's presentation, Workplace Hygiene Management during COVID-19. The presenter is Principal Consultant and Mycologist with GreenCap, Dr. Michael Taylor. Just a quick bit of background. So GreenCap is a national consultancy providing services in risk management and compliance since 1984 and has offices across each mainland state and territory of Australia. They initially started providing asbestos and hazardous materials consultancy, but now provide solutions across various facets of health and safety, including hazmat and environmental risks, just to name a few. So our presenter, Dr. Taylor, has an academic background in public and environmental health, microbial ecology and mycology. And Dr. Taylor has a research profile in the detection and spread of microbial pathogens in soil, air, water, and constructed environments, and has consulted for and worked collaboratively with both government and private industry to provide advice on human risk following exposure to potentially pathogenic microorganisms. Regarding COVID-19, Dr. Taylor has provided interpretation and application of World Health Organization and Center for Disease Control documents to provide advice for the safe handling and disinfection of critical medical services supplies, provided recommendations and gap analysis in virus management plans for power utility operators, and advice on suitable and effective cleaning processes with demonstrated antiviral efficiency. So just if you look in the bottom right-hand corner of your screen, there's a chat button there, which is our Q&A function. So if you have any questions during the presentation, just pop them through there. Okay, so I'll hand you over now to Dr. Taylor. Thanks.
Great. Thank you very much for the introduction, and thanks for having me. I'm hoping today to give you a little bit of a toolkit, sort of. I think there's a lot of really complicated information and rules, and it seems like there's a lot of studies that come and go and refute each other and that kind of thing. There are some core things that we know, and what I'd really like to talk about today are what we understand about transmission of this particular disease, the key principles behind what kind of safety measures you can enact. I want to talk a little bit about a few case studies where we know that externally where things have gone wrong, and then where we've been involved to make sure they go right. So that's sort of the background on what I'd like to talk about today. I'd like to start with this slide. I'm sure some of you probably remember the Codral Soldier On ad, the idea being, you know, if you go sick, you just continue business. If you get sick, you take the drugs, you feel better, and you go to work, and it's business as usual. And it's interesting that in hindsight, that ad did not age particularly well. There was, in fact, even a complaint leveled against it to the Australian Advertising Standards Bureau, saying that we understand how diseases are transmitted. Why would you tell people just to go into work when they're sick? And that's become all the more relevant now, unfortunately. But the complaint was dismissed. There was never any action brought against it, and the ad continued to run, which in hindsight seems wasn't necessarily the best decision at the time. I'm not going to spend an enormous amount of time on legislation and public health briefings and that kind of thing, but I will start by saying there is an obligation that employers, business owners, workplaces ensure that they are safe for not only the people that work there, but the people that visit them and use them, the patrons. That requires, to a degree, keeping up with the information put out by the Australian government, the various departments of health, and the in-state and territory government agencies. That's ultimately distilled into requiring that everyone has a COVID-19 safety plan or a COVID safe plan, detailing what measures you have put in place to make sure that people aren't going to get sick. But in a lot of ways, it's fairly similar to the pre-existing sort of safety legislation and your obligations as an employer in a business place.
Michael, so sorry, if I can just quickly interrupt. There's a few people having some issues. If you are using Microsoft Edge, the best browser is the Chrome. So if you switch to that, if you're not seeing the presentation slide, switch to Chrome. Thank you.
Sure thing. I'll just hang on for a couple of minutes until you say start again.
We're good to go here.
Okay. So in terms of where COVID-19 sits, it's very broadly in that big group of other workplace biological risks. And depending on where you are in the world and what you do, some of these things may well be very familiar to you. They're things that you deal with all the time. Some of them may not. And I think biological risk has been something that not only just nationally but internationally now has started to, it's no longer this sort of mysterious thing that hides in the background. I think it's becoming more and more of an understood risk that now needs to be managed. So I'm going to actually open it up to a poll here and ask, how many of those hazards do you actually recognize? I'll bring them up again, and hopefully I should be able to launch this poll, and you should have a prompt there. I'm interested to know how many of them you're aware of, how many of them are totally out there, and maybe if that's changed. So I can see a few responses coming in. It seems to broadly be, there are a few of them, and I'm imagining they're probably going to be things like Legionnaire's disease, which we pretty well understand how it works and where it is. HIV, most likely, and salmonella, particularly for anyone that works in a food handling business. And then we get into the more esoteric ones, things that maybe you've not really had a lot of opportunity to interact with. Thankfully, things like psittacosis, melioidosis is obviously something you have in the NT, and we don't in SA and other places. We have one person that says all of them, but for the most part, it seems like a few or only most of them, which is not surprising. In a lot of ways, though, these are just regular risks, and they sit in different workplaces depending on your interest. I'll close that poll. So for some of you that are either in veterinary services or farming and agriculture, things like Hendra and Hunter virus and the zoonotic diseases are probably very familiar. Food manufacturing is probably different again, but certainly COVID-19 is now one that we're all very, very aware of. So business is certainly no longer as usual. So I'll very, very briefly give a background of what this thing is and how it looks, what we understand about the state of play, and then move into what we can do. So it's in a big group of viruses called coronaviruses. That's actually an electron scanning microscope image of a coronavirus. From an actual structural point of view, this is how they look. So what that is actually made of is a ring of RNA in the center there, the curly bit, a series of proteins that hold it all in place, and what's called a nucleocapsid envelope. So essentially, it's boiled down to its most brief elements. It's a piece of DNA, or RNA in this case, in the middle, held together in a little greasy envelope with a series of proteins on the outside that help it attach to your immune receptors, the things that it'll actually bind to and make you sick. In terms of where we are in the world currently, we're verging very close to 40 million cases worldwide, of which about 27,000 of them are in Australia, a little bit over 1 million deaths, thankfully under 1,000 here, and about 27 million recovered, 25,000 in Australia. It's one of several pathogens that the World Health Organization has had on a watch list since about 2015, not this specific one, but MERS and SARS, which some of you probably are very familiar with, having worked in tourism and airports and that kind of thing. It was a coronavirus-based disease. It's something that we realized was out there, but and was possibly going to come back, but we obviously didn't know exactly when, where, and how. So as I briefly explained before what it's made of, you've got a center that contains all the nuclear information, a nucleocapsid protein, and a lipid membrane that hold it all together, and then the envelope and spike proteins, the bit that actually attaches to you. In terms of how big it is, this is something that is kind of difficult to visualize, just how tiny these particles are, which becomes important when we talk about transmission. If you were to compare one viral particle to one bacterial cell, like in E. coli that lives in your gut, it's about sort of depending on the virus and the bacteria, a 1 in 100 around about a 1 in 100 difference, maybe a little bit more depending on the size, on the bacteria comparing against. If you compare it against one of our blood cells, it's even tinier again. We're talking an order of magnitude such that you could have millions of viral cells, particles inside one of your cells, and they would comfortably fit in there. And then an absolutely minuscule piece of genetic information that exists in there. So we're talking really, really tiny. How it spreads, we certainly understand a lot more now than sort of January, February. In terms of the greatest risk, it's primarily by what we call respiratory droplets, the really small sort of bits of spit and vapor and stuff that come out of you when you cough, sneeze, even talk. And that's probably going to be during the first 48 hours before symptoms appear, is when you're probably at your greatest risk of spreading. It's when your viral load in your upper respiratory tract is probably at its highest, but also because you've not shown symptoms yet, you're likely still out and about and interacting with people. There is some evidence that aerosol transmission does occur. So that's longer than that 1.5 meters distance. They're the really small particles. And like I say, remember now, viruses are tiny, really, really tiny. That's the longer range transmission. They're the kinds of things that hang around in the air. And we certainly understand that contaminated surfaces and contaminated, materials that you touch with your hands and then touch your face also play a role. The infectious dose isn't known yet. There's not if you touch 10 viral particles you get sick number. That doesn't currently exist. It's not necessarily going to crack the case because it probably won't change the kinds of controls that we do. The usual onset's sort of 2 to 14 days, typically about 5 before you start showing symptoms. Duration is typically 14 days again. It can be as short as 5. In one case, I read a case study of someone that's at 180 days still showing signs of infection. But the thing that makes this one, I suppose, so difficult, so dangerous, is possibly up to 40% of people are asymptomatic. That means they become infected, they have viral particles that are in them that they can shed, but they don't actually get sick, as it were. They don't get all of the other flu-like symptoms, and so they can be out and about doing things and not even realize that they're infecting other people. So I thought it might be useful if we look at a couple of big spreading events where things have gone wrong and what we can learn from them, and what sort of information we can take and turn into recommendations. So the first study comes out of the US. It was a choir practice. It was in March this year. It's 2.5-hour choir practice attended by 61 persons, and one of them likely had symptoms. It was all traced back to one person in attendance. From that, one person turning up for 2 hours of singing, there was 32 confirmed cases and 20 probably linked to the event. By that point, it was difficult to definitively tie all of them back to one person here because the community spread had increased, but there was definitely 32 confirmed connected to that choir practice, with unfortunately 2 deaths resulting. So what happened? I mean, we're all pretty aware that close proximity is now a risk factor. In this instance, there was no social distancing being maintained. They were all in their traditional choir arrangement. Unfortunately, they were also in an enclosed space. It was an unventilated area where they were all packed together for a couple of hours. So any aerosols that were generated would have been trapped. So those respiratory particles that they were breathing out were probably circulating in that room and slowly building up and likely transmitting from person to person in a little cloud there. And singing, strangely enough, we know generates large volumes of high velocity respiratory droplets. Singing, yelling, coughing, sneezing, they're all surprisingly similar in a lot of ways. You're forcing a volume of air out of your lungs, and that volume of air is going to contain some of those infectious particles. So I've taken what we understand about breathing rates, and we measure this all the time for things like stress testing and athletes and that kind of thing. So we know pretty well what an average person does in terms of breathing liters per hour when they're at rest, when they're yelling, when they're speaking, that kind of thing. And so there are a few background numbers where you can begin to approximate how many viral particles they're going to shed per minute and per hour. So theoretically theoretically put in a few numbers there showing that if you were sitting just at rest on your own, you might be making 30-something viral particles a minute. But if you were yelling, we're talking in 2 orders of magnitude higher, probably thousands of particles. And if you have 60 people all in a closed room, all singing for 2.5 hours, you're going to end up with a lot of circulating viral particles that you're probably, as gross as it sounds, splattering all over the people around you. So it's pretty obvious what went wrong there. Guangzhou restaurant, the next case study, which in some ways looks similar, but it's definitely different. We're beginning to see that there are a lot of clusters of cases turning up related to food service and restaurants and that kind of thing. So this one was January, February this year. It was a busy restaurant. It was a 5-story restaurant, so quite a huge facility, with 91 people on this particular floor. So 83 customers, 8 staff. Of the 91 people there, only 10 were infected, and 73 were quarantined. The paper doesn't go on to talk a lot about their prognosis. So what's interesting about these 10 people? Why do we really care about the 10 people of the 90 that got sick here? Now, the interesting thing is in this particular study, they actually looked at who got sick and placed them at each of their tables and said who was sitting next to who and what happened. So this is a little floor plan of that particular floor of the restaurant. So each of those circles is a table. The air conditioners, which they particularly take note of, are on the right-hand side there. And this is the only area in which anyone got sick, which is interesting because when you look at all the people, at person A1 there, the highlighted person was the index case, the person that actually turned up and showed symptoms, and only people in this spread, this one line of tables all got sick, and no one else throughout the restaurant, no staff, no one on tables E and F. And what we know about the people that got sick is they didn't contact each other outside of the restaurant. They didn't know each other. But what went wrong was they were likely in close proximity to one another with raised voices because it was a loud restaurant. There was only that one person that was identified, but the air conditioner in that instance was sort of highlighted as producing what's called a recirculation envelope, or kind of like a volume of air that turned round and round and round, which didn't really spread to other parts of the restaurant. So it sort of circulated in this corner here, this area of sort of air moving round and around that didn't really spread out anywhere else. It probably blew from one area over to the other and back again, but it didn't transmit particularly far, which kind of, when I talk a little bit later about the controls you would make to ventilation and increasing airflow and making sure you've got adequate exhaust and those kinds of things, this is just a nice illustration of if it's not set up right, it can actually be very, very wrong. And I'll very quickly touch on another one that's actually a good news story now, one that didn't go terribly wrong. It was a study done in German schools. It followed kids under the ages of 19, and essentially they wanted to look at what control measures were put in place across all of these different facilities in order to work out where transmission was being spread and if enough was being done to make sure that children didn't transmit it to each other and then bring it home. So they looked at all the different control measures that had been enacted, whether they were making sure they were maintaining social distancing, the cleaning. They recommended that they wear masks, whether that was in classroom or out of classroom, those kinds of things. So they took note of all these things and came up with a few commonalities. For the most part, they did their best to maintain that physical distancing, recommend masks are maintained, recommend children don't come to school. All of them said don't come to school if you're sick. They cancelled singing practice. They cancelled physical education to reduce the likelihood of people bumping into one another and come in contact with each other's sort of yelled out aerosol particles and that kind of thing. And they found that a lot of these measures actually worked. Schools reopened, and during that study period that you can see there on the right-hand side of the graph, the number of infections driven from schools was actually pretty low. It was, for the most part, looked to be, when they looked at where people had gotten sick when they did that contact tracing, mostly from households, which likely meant it was coming from communities, not from schools. So when you have a controlled number of people in a controlled environment and you make sure they're mostly doing the right thing, it actually seems to have an effect. So what is this actually telling us, and what can we turn it into? What can we use this information for to actually help us here. So I'll open the next poll now. I'm sort of interested, I've sort of stacked the deck a little bit now, but what do you think is the biggest risk in terms of transmission? So you should have had a poll pop up now. You've got aerosols, close contact or inability to maintain social distancing, contaminated surfaces or materials or high touch points or that kind of thing. Or this is a difficult one because this sort of goes across every year's bad behavior, no face, no hand washing, face touching, sneezing, spitting, that kind of thing. And like I say, I did stack the deck a little bit, but it's actually interesting when you look at this. It may not be 100% uniform across every environment, every scenario. It's likely to be a combination, and that ratio of which one's going to play the biggest risk might shift. So it's probably important to note that zero risk isn't practically achievable. You can reduce it by a lot, but unless the hazard no longer exists, the risk is probably there, although very, very small. So some controls are likely better than others, and that's going to be influenced by the environment or the location where the people are, the number of people that turn up, the activity that's being conducted, and the number of infected people in the population. It's sort of a multivariate thing. You can't just say, if we always make sure we do X, we'll always end up safe. Unfortunately, you probably have to risk assess, or at least look at what you're doing, the activity, and make sure that you're appropriately putting controls in place. So, I mean, if we were going to look at, say, a crowded theatre, you've got a whole lot of people sitting together for a period of time. They can't move. Aerosol might play a really high role. That close contact, inability to maintain social distancing might come in a close second. And then things like contaminated surfaces might be less because you haven't got all these people moving around and touching stuff and interacting with things. If, say, for example, you had a primary school, though, and controls were not put in place in the same way, or a kindergarten or something like that, you might have a lower risk of aerosol and a little bit more of kids interacting and bumping into one another, probably a whole lot of surfaces being contaminated because kids are kids and they cough and they sneeze and they wipe their hands on things, and that a little bit more in terms of behavior, because it's difficult to get compliance in a group of children to do anything, let alone wash their hands and stay far apart and do that kind of thing. And so depending on where you are, those risks might shuffle to a degree. It might be more important that you control spacing in one, and more important that you control, hand washing and cleaning and sanitization in another. So you really do have to look at the activity and work out what's going to be your transmission risk and what you can do to reduce it. So like I say, that environment will play a role. So indoor versus outdoor will be important, and that's certainly increasingly important if you're looking at outdoor activities and tourism related events and that sort of thing. When you're outdoor, obviously your residence time of aerosols and respiratory droplets and that kind of thing changes. It's likely going to decrease because you've got that greater volume of circulating air to dilute those exhaled particles that come out. It should be easier to maintain that social distancing outdoors. You've got space, you've got the ability to segregate groups out and push them apart, and there's likely less items to interact with. In an indoor space, we make them comfortable by putting things like chairs and tables and magazines and that kind of thing, but in an outdoor environment, you can probably be assured there's less of that. If people are moving around or they're stationary, that's going to change the dynamics as well. As people sit, there's obviously less likely going to be interacting with a whole lot of different items. But obviously, if you sit people too closely together, then you start to interact with each other's respiratory droplets, and you end up with a different scenario. The activity being carried out is also going to play a role. If you have, the local district yelling competition, that's probably not a great idea to carry out, particularly if it's in close proximity to one another. Anything involving high touch points and frequently handled items or shared items, you're probably going to run into controls needing to be placed around cleaning and sanitation. And can hand and face hygiene be achieved or enforced? That's going to be based upon a whole range of things: sanitary facilities. Can you actually get hand sanitizer available? Is that going to be appropriate? Really will depend on the activity. So as I say, I'm hoping that as I go along, I can give you some tools to actually look at these problems and then pull them apart and work out what you can appropriately put in place. Something I'm not going to harp a lot about, but is an interesting thing that we're understanding more about, is fecal shedding. Interestingly, infectious viral particles of SARS-CoV-2, the virus that causes COVID-19, can be shed when you go to the toilet. So there has actually been some studies done showing that aerosols generated from flushing toilets that reside in little cubicles and that kind of thing may actually result in infections. So well-ventilated toilets may actually be of assistance, and not just for odor control, from an infection control point of view as well. So what do we actually know works in terms of reducing risks? It's difficult to put a quantifiable number on things. It's unfortunately not as easy to, you can't definitively say in every circumstance, if you do social distancing, it'll get rid of 99 point whatever % of infection risk. It doesn't quite work like that, but we certainly know that that distancing works. If you can reduce the human density and keep people spaced apart, it removes opportunities for people to touch and interact. It allows those respiratory droplets to settle out, and the bigger ones generally do within a couple of meters, and it reduces the likelihood of encountering aerosols, and particularly if you're outside. We know that the good hygiene works. Cleaning is one part of the story, but the other part is obviously if you touch something with your hands and it's not clean, washing your hands stops you then transmitting it back to your face. There's certainly an education aspect to making that work, and that's very hard to change human behavior, but being mindful not to touch your face, enforcing that in not only people if they turn up to your workplace, whether that's workers or patrons, but having up signage and those reinforcing things makes sure it's front of mind. It's also, you can greatly increase compliance when you make it easy for people to comply. So if you have good access to hand washing or hand sanitization facilities, hand sanitizer, that kind of thing, we're all really used to seeing it now, but having it available makes compliance easier to achieve. And then some of the basic good hygiene stuff, like making sure people cough into their elbow or tissue, make sure that they dispose of things that they've coughed into, contaminated PPE, so masks and gloves and whatever, in appropriate bins and not just laying around. All that kind of good hygiene, good housekeeping stuff does actually play a role. We know that good ventilation certainly plays a role. Reducing the amount of time spent in closed spaces with multiple people is a really useful tool, as well as increasing the fresh air and reducing that recirculation. So, for example, in a car, if you had the air conditioner on and then just recirculating that air round and round and round, that might be a problem. If you're in a closed meeting room with a group of people and no fresh air, once again, you may be creating a problem there. Wearing masks could be used to mitigate some of these spread and interaction with respiratory droplets. Certainly the wearing of masks does knock down some of those bigger ones you breathe out. If you just can't get that good ventilation, then there's no other way to avoid it. You have to be in close proximity. As best as possible, the advice is to limit that to less than 15 minutes. Otherwise, you really start to enter in a potential scenario where infections could occur. And we know that good cleaning processes also works. So eliminating the number of things you need to clean. So the common and community items I mentioned before, magazines in a waiting area with things like, toys that people play with for children, anything that people naturally interact with, pens on a counter and that kind of thing. If you can limit the number of those things that need to be interacted with and cleaned, whether that's by introducing touchless or no touch services or that kind of thing, does make life easier, as well as using effective chemicals directed at those high touch points. So handles, light switches, toilet fixture and fittings, those kinds of things, lunch tables and what have you, areas where people have to touch and interact with them, making sure that they're cleaned on a regular frequency with an appropriate chemical, and making sure that your cleaning staff know what they're doing and why does help a lot. PPE can be useful. It's something that in some instances is pretty close to required, but depending on what you're doing may not strictly be necessary. I mean, right at the beginning, we saw that there was an enormous shortage of some of these basic PPE items like gloves and masks. We were sort of triaging them so that there were more available to healthcare workers and first responders and that kind of thing, but they're a little bit more available now. Respiratory protection is something that we talk a lot about. It's likely very important in areas where you know that there are people that are infected, where social distancing is difficult, where aerosols are being generated, where you need to be close to other people, and can't avoid it, unfortunately. So fluid-resistant surgical mask or cloth mask for people if you're out in public. If you know you're going to be interacting with infected in a healthcare setting, then you're looking closer to proper respirators that require respirator fit testing to make sure that they work, because your likelihood of encountering those aerosols is significantly higher. From a business and general public point of view, you should always look at the activity you're doing, but a fitted respirator may not be necessary, whereas just a mask may be useful. Impermeable gloves, we've certainly seen a lot of varied use and sometimes confusion about the use of gloves. They're very useful as a barrier, particularly if you're mindful that you're wearing them and you know how to put them on and take them off. If you're working in an area that is likely contaminated or you're doing cleaning, they can be a really useful tool so that you can put another layer of protection between you and contamination. They can be really useful where hand hygiene is difficult to achieve, but you should always wash and sanitize your hands afterwards. The thing with gloves, though, is that if you just treat them as your hands, in essence, they are your hands. If you wear gloves and you touch surfaces and then just touch your face, you're not really doing anything. You're just transferring viral particles on a glove rather than your fingers. So understanding what gloves do, how to dispose of them correctly, how to wear them correctly, and when you might need them is kind of important. And then we go into the more high-level PPE stuff, things like coveralls and Tyvek suits and aprons and that kind of thing. They're likely going to become a hindrance if you're in a fast-moving or lifting and carrying kind of environment. They might cause heat stress and that kind of thing. They may not necessarily be appropriate unless you're really likely to come in contact with a lot of contaminated goods and need to protect more than just your hands and your face. That's the kind of thing where you might be moving around maybe contaminated laundry or something like that, but it's not likely necessary in a lot of workplaces and environments. What we understand about how long SARS-CoV-2 lasts on surfaces, we know that for the most part it's going to be driven by things like temperature and humidity, where lower temperatures are likely to maintain things for longer and higher temperatures are likely to break the virus apart much more rapidly. For a lot of surfaces, you're probably looking at a day or a few days at most. Copper and brass and those kinds of things tend to be antimicrobial to a degree and will break viral particles down. Aluminium, steel, polypropylene, that kind of thing, because they're fairly inert, you may have a few days of residence time on a surface, and so that cleaning and sanitizing for things like grab rails and buttons and high touch points probably becomes increasingly more important. There's been some studies that have come out very recently saying maybe that could be extended up to 28 days. In all likelihood, a lot of the control measures put in place will continue to mitigate that anyway. If you're cleaning on a daily or twice daily or every time someone handles something kind of regime, then you've already provided an intervention that is more fast acting than that. So if you're cleaning twice a day, to a degree, it doesn't matter if the viral particles persist for a day or 2 days or 5 days or 10 days, you're cleaning with such a frequency that you're removing it in between each of those uses. And so you've determined what the risk factor is and you've put in place a measure to reduce that. In terms of that cleaning methodology, what it should be directed at and what we know works, again, like I say, those high touch points really become key. So in a lot of building scenarios, you're looking at things like door handles and elevator buttons, phones and keypads, or any shared equipment or tools. From a broader perspective, you might be looking at things like if you have an activity that requires everyone uses grab rail when they're getting onto, say, a bus or a boat, or if everyone was handling the same, bit of show and tell equipment or something like that. If you can't reduce people interacting with those objects by, say, you look but don't touch, please, those kinds of things, then you really need to make sure you've got a good documented cleaning policy in place so that it's really clear what has to be done and when by who. So make sure that if you have a cleaning contractor, they're aware of that cleaning policy and what they should be cleaning. It needs to be effective, so using the right compounds against the right targets. It needs to be the appropriate sort of frequency to make sure that if you have 5 groups of people through a day, you clean in between each one, that kind of thing. It needs to be rationalized as much as possible. What we know works, there is actually a lot of chemicals that we know are effective. Luckily, this is in terms of its structural integrity. These lipid encapsulated viruses, they break apart fairly rapidly once you use detergents. So soap and water is actually pretty effective in terms of disinfectants. Sodium hypochlorite, which is bleach, essentially, quaternary ammonium compounds like benzalkonium chloride, alcohol, so ethyl alcohol and isopropyl alcohol, which is what is in the good hand sanitizers, is pretty rapid, 30 seconds or so. So there is a range of compounds out there that we know work really well. There are a few big lists of compounds with demonstrated antiviral efficacy. The Therapeutic Goods Administration in Australia here maintains a database, so does the US EPA, of compounds that meet that minimum criteria for antiviral effectiveness. So you can actually look things up if you want to know if a product works or not, as well as just looking at the formulation. Fogging, air sanitizing, fumigation, whatever you want to call it, is another thing that comes up a lot. It's often used to sort of say sanitize a whole warehouse or a whole shipping container and that kind of thing in other industries. For infectious viral particles like this, it becomes a complication which might actually not be worth doing. It's difficult to dose for a start because the concentration that you put in the air is going to depend upon the size of the area that you put it in. So a small bathroom is different to a warehouse. It's sometimes applied sort of prophylactically to clean the air. I know there was a few airports that were spraying chemicals into the air for a period of time, but increasing the ventilation is likely going to be safer. It's going to be constant because you've just upped that fresh air, and so you can maintain it much, much better. Fogging isn't endorsed by the Centre for Disease Control or the Australian state-based Health and Human Services departments, and that's for a range of reasons. Not only may it be damaging to, say, your ventilation systems, your carpets, furnishings, what have you, depending on the compounds, but the risk reduction that you actually achieve is possibly or most likely not as effective as just having those good hygiene principles and good high touch point cleaning protocols in place. If you go a little bit further, people who aren't really familiar with this kind of application may end up putting themselves at risk if they're not adequately protecting themselves from a respiratory point of view. Particularly, they may well be unintentionally poisoning themselves because they're doing something new that hasn't been properly risk assessed yet, that they're, is an unfamiliar process to them. Going even a step further again, there is now studies coming out saying that there's likely to be an accumulation of these cleaning products in the broader environment. We're seeing now a really big uptick in persistent antimicrobials, so quaternary ammonium compounds is one of them. And if you start, I don't want to say indiscriminately spraying them everywhere, but that's close to what this could be, you end up with an accumulation in the environment that is possibly going to have on-flow effects, particularly in aquatic environments and those kinds of things. And so if you're applying them in any, anywhere where you may have a sensitive ecosystem nearby, you're beginning to provide a greater degree of risk to other areas, higher level impacts than what you achieve in terms of risk reduction for disease transmission. So the bottom line is steer clear of fogging and fumigation. Testing, monitoring, and clearance of workplaces is something that comes up as well. It's difficult to do effectively for lots of reasons and only lasts as long as it takes people to come back into the workplace again. There are tests that look for the actual bits of nucleic acid, so the swab tests. There's a few more rapid tests, but in the turnaround time to get it back, say 2-3 days, maybe longer, you may well delay reoccupying workplaces and buildings where that good, robust documented cleaning process is likely able to supersede that and get the job done quicker, whereas a clearance may not necessarily provide you anything greater if you know that your cleaning contractors are doing the right thing. So how do these changes actually look in a workplace? Make sure that you have a clear COVID-safe plan. Anything that you've changed, those protocols, changes to facilities, occupation numbers in rooms, social distancing, that kind of thing, make sure it's clearly signed and communicated. Make it easy for people to do the right thing, but also have a plan to know what to do if things go wrong. Have a process for if someone turns up and they are sick or they become sick on site, where you put them, have a dedicated area or space for them to go. Make sure you know who to call, the various health departments, and so NT WorkSafe or Safe Work SA or wherever you are in the world will have a process for what you should do, who you should notify, and what the next steps are. Really simple ones are don't admit people to the workplace if they're unwell or if they've come from high-risk areas. That obviously counts double if you have a transient population of tourists that come through, making sure that they haven't come from an area that's likely got a high viral load in the background. Changing your processes to minimize the handling of goods by customers. It can be really awkward and difficult, but we know that that can help if you say, please don't touch things unless you're going to buy them, or let me handle them for you if you'd like to see. And similarly, minimizing the number of shared objects or tools or stationery, whether you're tradies on a work site or people in a canoe sharing oars or binoculars or whatever. Make sure that as much as possible you minimize handling and passing things around between groups, or limit them to very small groups of people that have, say, traveled together or are a family. You know that they're all going to be of the same, theoretically the same viral status, and have a policy. A lot of it just comes back to having a documented procedure for what you do and why. And that can be both driven by the employees and the cleaning contractors to understand what needs to be cleaned and why and when. Education is always key. It's very difficult to overcome human nature, but providing reminders and front of mind bits of information, whether that's obviously visible signs and posters, letting people know what the requirements of coming to your workplace are, where the hand sanitizing stations are, how access has changed, how many people can be in rooms at a time, that kind of thing makes it easy for people to at least know what the right thing is. Reorganization is probably going to be key, particularly where previously people have been able to queue and congregate in no particular order. You were likely going to have to put some kind of structure in place to keep that social distancing in place if you want to really make sure you reduce transmission. So barriers to wandering through uninhibited, but also in between, say, a service counter and customers, floor markings to help remind social distancing, changing queuing to make it a little bit more structured can certainly help to stop people being close enough that respiratory droplet transmission occurs. Restructuring activities to minimize, I've called it cross-pollination, but it essentially just means that bumping of groups into one another. Whether that's segregating work groups or reducing mingling before and after activities, making sure that people are kind of blocked into groups and keeping them a little bit separate. Altering access to facilities so that as much as possible you've got an entry and an exit so that people don't have to sort of jostle past one another can make a big difference. And moving to those contactless services to minimize handling of cash, handling of stock, that kind of thing. In a lot of ways, that just reduces the amount of things you have to clean, but it reduces the amount of stuff you have to handle as well. That social distancing, it's more important for some activities than others, but reducing that time spent crowded together in a closed environment is quite key. And as much as you can, like I say, alter those processes to minimize congregation and queuing. Whether that's just spacing people out a little bit more, having smaller groups go through, say, a trail or a path or something like that, so they're a little bit more spaced out. Maintaining that good hygiene, like I say, providing hand sanitizers at strategic points, so entering and exits, making sure that those items are clean and disinfected, and having a documented procedure for what you have to clean, when and why. Contact tracing is something that we didn't talk a lot about 12 months ago, but now it seems to be something that people understand pretty well. It can be really useful to have a way to capture and retain that contact information. There's obviously privacy laws around that, making sure that if you do collect that information, it remains confidential and has a disposal date on it. It's currently required in other jurisdictions. I don't think it's currently required in NT unless someone's come from one of those areas or is currently quarantining. But that can assist certainly if something does go wrong. Increasing ventilation wherever possible. I've mentioned it a heap of times now, but that becomes really tricky in, say, a vehicle. So if you were looking at, say, a bus or a four-wheel drive or something like that, you may want to have a protocol in place where you designate a driver who does all of the handling of the controls. Don't recirculate air. Have the windows cracked a little bit. Consider wearing masks if it's going to be a long trip. If you have a work group that has to travel together for a period of time, make sure that they don't, have one person swap out, another person swap in. Try to minimize it to a team or a cluster or something like that, just to reduce that sort of cross-flow effect between different groups. Things that would be red flags are, say, a hand sanitizer that contains very little active content, nothing. So, for example, no alcohol. And certainly there are some that say all natural is something that often makes me cringe because it typically means doesn't contain a known effective compound. So we're talking about at least 60 to 70% alcohol in a hand sanitizer, although hand washing is still the preferred method. Another red flag would be indiscriminately giving people PPE without actually letting them know what's required, how to use it, and where to get rid of it can be a problem. If you get people to put a surgical mask on, but you don't actually show them how, I'm sure we've all seen photos now of people with masks pulled down onto their chins and off of their nose and off to the side or upside down, I've seen a lot of times, and then disposed of inappropriately. If you give someone a mask and they don't know what they're doing, they may actually touch their face more to adjust it. So a little bit of instruction goes a long way, as well as disposing of these things. If you're in a sensitive environment or out somewhere where there isn't a bin, for example, make sure that stuff doesn't just get thrown on the ground or away indiscriminately, not from just a litter point of view, but because someone has to pick that up. And if it's contaminated, then you've created a point of contamination, unfortunately. And make sure that if you do a risk assessment and determine that PPE is required, make sure that it's appropriate, that it doesn't hinder movement, it doesn't become a heat exhaustion risk if you're out somewhere warm. Make sure that the controls you put in place as much as possible mean that a PPE isn't required, with that kind of control put in place only if you really need it because of those limitations. So I'll finish off with a case study, something that sort of speaks to some of these principles. We were engaged by a group that runs seminars. Essentially, it was an independent think tank for international policy that hosts regular events, Q&As, that kind of thing. And they wanted to reconvene to restart work. They wanted to keep going with what they do. It's located in a major Australian capital city, so there's a dense population. There were currently active cases. And in these particular speaking events, they were held in an indoor environment with food and beverages being served. So pretty well, all of the things you could do that could pose a risk were there. So as a really rough overview, essentially there was a main speaking room and then a downstairs bathroom area and a food surface area. So I've just dropped the doors in there in green, but that's a really rough layout of the space. The speaker and audience were all in one enclosed room in a traditional kind of lecture style, with the staff placed inside there to assist, move microphones around, find people who wanted to ask questions, that kind of thing. And the attendees were fairly free to move about in the space, go to the bathroom, mill outside, that kind of thing. So what we did was immediately we controlled access to a degree. We closed the doors leading into the building so that we had, people would come in and then out of one door and sort of in one door and out the other, so we knew what the flow was going to be. Internally, we made sure the doors remained open to increase ventilation. We made sure they did an assessment of how their air conditioning system worked to make sure that there was sufficient ongoing flow. The air wasn't just being turned over, it was being ventilated. We suggested they consider masks if people had to all cluster together in that room. and spaced the capacity out. So we essentially reduced the number of people that were going to be in that room at any one time, and then moved them a little bit further apart from one another. We moved the staff to outside of the room so they could service the room if required, but weren't strictly adding to that space. We set up clear waiting areas for heading down to the bathroom, for the food service area, and for queuing outside to make sure that things happen in an orderly fashion. We let people know ahead of time what was going to change in terms of access to that facility. If they were sick, they had to make sure they didn't turn up, those kinds of things. And then we made sure that the microphones that previously were going to be passed around, they were on podiums that weren't touched. We changed food service so that there was no come and take yourself self-service things. There were pre-packaged portions that people could collect without having to interact with any other materials and surfaces, and then dispose of without having to, rifle through a pile of cutlery or operate a tap to get water or those kinds of things. As much as possible, everything was redesigned to minimize the amount of areas, materials, surfaces, and items they had to interact with, as well as just reducing the density of people in any one space. So I suppose what I'm interested in now is, before this all happened, you may well have had an industry-specific risk, say, for zoonotic diseases or something like that. But I'm interested to know, did you have a pandemic plan pre-COVID? Did you have something in case, if thinking about swine flu and MERS and bird flu and all those other things, did you have a pandemic plan in place before this year? And do you have one in place now? Is this something that you've taken up and made sure that you actually got going forward? So you've probably got controls in place for COVID, but have you thought about what happens next for who's going to do the disease surveillance, who's going to make sure that they've got lines of communication, whose job it is to do certain stuff? I'm extremely pleased to see 100% of people all say they have a plan now. A lot of the stuff that goes into the pandemic planning more broadly is really just good documentation. It's good policy. It's things like making sure there are clearly defined roles for when a plan is enacted, making sure everyone knows what they're doing, having a monitoring program in place. When are we going to turn the plan on? Whose job it is to look at the news? Who do you report it to? Identify what critical operations have to keep going and what your supply lines are. Identifying your high-risk workers and clients is really key. Certainly if you're operating in an industry where you've got a range of different people turn up to use your services, if you know that there's going to be someone turning up who is very high risk, whether you identify them and make sure there's extra controls in place or change the way you operate is really important. Controlling access and travel and implementing those kinds of plans we've talked about, whether that's cleaning or hygiene or just worker health reporting and that kind of thing. Please have one in place. If you need that kind of assistance, this is exactly what we do. So please seek out some help. We're happy to put it in place and look at all the bits and pieces that makes your business run and assist you. But having a plan is kind of critical. So good job, everyone, for sticking with it, not just this talk, but pandemic planning in general. Certainly, there's a period that we're in where it feels like we're absolutely exhausted with all the controls that are in place, and it would be easy to stop. That's the worst time to stop. Keep going. We are close. We didn't overreact. If everything goes well and all of your plans work, it'll look like we overreacted and nothing will happen. It'll just return to normal at some point. If we get lazy and we stop and we continue with business as usual, that's when things go wrong. So it's really hard to maintain these kinds of controls when everything seems to be going right and the risk is low. That's when it's easiest to slip and the best time to keep going, unfortunately. As dull as that is, that's kind of the way these things work, unfortunately. So we've come to the end of the actual seminar chat bit. Please ask questions in the chat box. There is a handout, a checklist for you to pick up that I can share that has some of these things, these checklists, these items you can go through to make sure you've done. It's not comprehensive. It doesn't tell you how to write a plan. It just tells you the kinds of elements you need to look at in your plan. So I'll open it up to to questions. I'll allow the moderators, so Peter and our side moderating the seminar, to have those questions start coming through, and we can probably move into the Q&A bit now. Please feel free to ask questions more widely. If there's anything that's particularly on your mind or you're interested in, whether it's testing of humans or testing of workplaces or transmission or industry-specific stuff, please feel free to open it up. If I don't know, I'll let you know, but hopefully there's a few interesting things that turn up that we can at least talk about how they work and what we could do.
Okay, so Ron, it's Peter here. So to access the chat function, there's a little blue box on the bottom right-hand side of your screen that says chat. So if you click on that, it'll open up a side panel, and then you'll see at the top of that side panel, it says chat and Q&A. So just click into the Q&A section and type any questions that you may have.
Certainly in previous talks, I've had some interesting questions regarding things like, I had someone talking about fake nails. Okay, thoughts on mandatory testing. Should employers enforce testing? That's an interesting one. Testing more widely in Australia has not been enforced. It's not been something that we've really brought into our management landscape. Certainly in the US, there's a lot more discussion of the kinds of tests being used, how quick they are, how frequently they should be used, and there is a few tests out there. There is a big push for what they call $1 a go tests, where you can screen someone very rapidly 2 times, 3 times a week, something like that, and then use that as a monitoring strategy in your workforce. Obviously, everything has a cost, and not only does that cost time, but if anyone's going to be doing those tests, you have to make sure that they're not actually a transmission risk themselves. It seems like it's probably quite important, only because if we're looking at 40%-ish asymptomatic people who might be carrying this disease without knowing it, so silently spreading it, then a robust testing regime would make sense. Whether it's enforced or not is difficult to say. It really depends on the workforce. And I mean, one of the things they're looking at in the US particularly is universities, where you've got a whole lot of people that all turn up, thousands of people all turn up to a space rapidly, and then can go back out to the community, where they've said this twice a week testing is how they're going to run. That's not uniform, but certainly they have a few more things available. The tests that we're using now, really briefly, I'll wrap this question up. I know I got technical. There is essentially an antibody test that you test in your saliva that is relatively rapid. That gives you a return without any specialist equipment, but it's not hugely sensitive. Sometimes those swab tests that you see where people put a swab in your nose, they're more sensitive, but they take more time. You have to send it away to a lab to be sort of confirmed and that kind of thing. So someone was talking about putting in a policy where if you get a positive with the quick test, you confirm it with the slow test, and then you run it like that, and the person goes home in the meantime. I think it could be a very useful tool, but I don't know if there's the appetite for that in Australia, considering our low baseline level in the community. So I think it would be a great idea. Whether it's able to be achieved is very difficult, so it's a complicated one. Okay, is there more information on how long the virus remains on surfaces? I'm interested in paper and books, keyboard, polyethylene surfaces, sofas, lounge chairs, etc. Okay, there is a good amount of information out there. There's some good studies that were done early on that looked at not only this particular coronavirus, but similar coronaviruses. So MERS and SARS were both coronaviruses, as well as a model coronavirus called 229E, where they looked at how long this thing lasted on a surface by essentially putting what they call an environmentally relevant or a clinically relevant dose on the surface. So you know how much is coming out of you, you put it on a surface, and then you measure how long it lasts. And how long it lasts is different to how long it remains infective for. It can fall apart and you can still detect it, but it's not actually going to get anyone sick. For clean, inert surfaces, stainless steel, polypropylene, plastics, aluminium, those kinds of things, your probably looking at, depending on how much gets on the surface, a day or so, maybe 2 days. Cotton, paper, absorbent materials are probably going to be a little bit less in terms of transmission because they absorb, they hold onto particles. A lot of them will come, like paper and cardboards, often come with bleaches and antifungals and stuff built into them, and so they are inherently a bit less likely to survive on that surface. Cotton, wool, and those kinds of things, as they're also absorbent, also tend to hold onto particles, so they're less good at transmitting and recovery. There is a lot of information out there about how long it remains on the surface, but it seems to be, like I say, it'll be dependent upon how much starts on the surface, and then how long it slowly dies out. So a few days is probably a reasonable guess, even less than a day, even though there are studies now saying much, much longer. That's sort of under ideal circumstances where in one particular study, they didn't expose the surfaces to UV. They maintained a very constant temperature and humidity. They put the virus in a carrier medium, essentially a liquid that made sure that it was relatively comfortable on the surface, those kinds of things. So there will be a degree of fluctuation depending on lots of stuff. If it's dirty, if it's got cleaning chemical residues left on it, those kinds of things. Happy to send studies and publications if that's what you really need, but it is one that is complicated. Question from the venue. Some public toilets in the NT do not have toilet lids. Does this mean the venues need to regularly clean the cubicle walls and doors? Or would the poor airflow in some toilets be an issue? That is a really interesting one. In terms of ventilation, is probably going to be more important than sterilizing surfaces, only because let's say it was on walls and floors and that kind of thing. For the most part, you don't interact with a wall and a floor in a toilet that much. You don't touch the floors and you don't touch the walls, and you're likely to wash your hands before you leave. So the touch-based spread is probably going to be a smaller factor than the ventilation. So ventilation is probably going to be more important there in terms of reducing the residence time of an aerosol. So actually bringing in fresh air and pulling out the contaminated plume, if you will. So poor airflow is probably more of an issue than surfaces, I would say, just based upon the way we use those spaces more than anything. It's really only a factor in modern flush toilets. The things that really gush and turn the water over is what actually makes the aerosol. As weird as it sounds, a long drop or something like that is probably not going to constitute the same kind of risk, because you're not actually making an aerosol. It's just ending up where it ends up without being physically turned over in sort of like a rolling thing of water. The NT is COVID-free with social distancing measures in place. What are your thoughts on introducing extra controls such as face masks and covers now? It's like I say, it'll depend upon a lot of these control measures, and when you do a risk assessment, particularly for disease transmission in a population, are not static. It's COVID-free. Yep. Now, if that was to change and no one had planned and decided that we might need to bring masks in at some point, then it becomes complicated then, because if nothing was ready or nothing was in place, there was no policy, there was no monitoring or surveillance, that kind of thing is where you really fall into a trap there. So it really becomes not just a matter of what the environment is it likely to be conducive to disease spread, but also what's the base load in the community, what is going on, but also what's going on elsewhere. If you had an enormous flare up in all the surrounding countries around Australia and we had our borders open, you may want to have a plan in place where you say, now we use masks. So it's worth having a policy with some mechanisms that you can say, we might not need this now, but we have a plan in place for if we do, rather than saying everyone must never wear masks from now on forever, is probably not going to be achievable either. You have to have a look at what you're doing in the broader environment to really make that decision. And unfortunately, it's not binary. It's not on off to a degree. It's based upon what else is going on, at least in my opinion. If there is only one window in an office of 3 to 4 workers, should the workers be positioned away from the window to be away from the inbound, outbound airflow? I'll try not to make this one complicated, but it's an interesting one because there's a few studies that have turned up saying where some people have gotten sick, where they've had a whole lot of people in a room and a high velocity fan blasting air in one direction across all the people in a row. So if you have one person sick at one end of the factory and not elsewhere, and you have air that just blasts linearly across, you might spread viral particles across those people and actually get them all sick. What would be ideal, what's even better, is if you have the ability to ventilate the space so that air comes in and out, whether that's exhaust fans or return an air supply that you make up more fresh air or something like that. Seated next to a window, if you've only got one window, you're probably not going to have a significant amount of air blasting in and out, because if it's only one window, it's kind of fixed to a degree in terms of the ventilation in and out. You're not going to have a continual flow through where everything accumulates and goes out. I'd really need to know how your building was set up and that kind of thing, as to whether that's a risk or not. I would probably say it's not a risk. If you've got a whole lot of people in that space and they're close to one another, it may constitute more of a risk just from a health and safety, from a transmission point of view, but from a ventilation, aerosol, respiratory particle point of view, it can be complicated. I don't think necessarily sitting next to one open window is going to increase your risk. No. I think that's most of those questions that have popped up. If anyone feels like I didn't get enough meat in their question, please let me know, and I'm happy to jump back in. Or similarly, send us an email. I'm happy to provide you some of the links or PDFs of any of the studies that I've pulled apart for this particular talk. I know there was quite a few in there. If they're relevant and you feel that they could be useful to you, I'm happy to send them along. One of the nice things about COVID is a lot of the time academic publications have been held behind paywalls, and publishers have held onto them pretty tightly, and you have to pay per look. A lot of that for the COVID stuff has been stripped away. So a lot of these things can be picked up and freely shared around because they're such important information. And if there is anything in the slides that I spoke about today that you are interested in, I'm happy to send you through the actual studies that it referred to so that you can pull it apart yourself if that's really useful.
All right, so I did notice that a few people entered the presentation after it started. We will be making the a recording of this presentation available on NT WorkSafe's YouTube channel in a week or two. So if you've missed the first part, please check back later and it'll be there. But if there are no further questions, we'll wrap up the session. So thank you very much, Michael, and thank you everyone for attending.
Great. Yeah, thank you very much, everybody. There is a feedback form. I would really like to know what you thought about this, if this was useful, if there's specific things that your industry want to know about, please let us know. Feedback can be really, really helpful here because we're not talking about a single industry here. There's so much of what you do that's also different, that it was really difficult in an hour to have one answer for everyone. Like I say, I really wanted to make a toolkit or some practical things that you could attempt to enforce and some rationality behind it so you can decide what, when, and where is really going to help you out.
All right, well, thank you so much. Yeah, everyone have a good day. Thank you.
Thank you.